I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.
Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. We're so happy to have all of you joining us today, or tonight, I should say, for our broadcast and our very special guest, Dr. Kyle Hogarth, who's the professor of medicine in the section of pulmonology and critical care medicine at the University of Chicago. However, he will be joining us tonight from his vacation in Wyoming, and we are thrilled and so grateful that that he offered to continue with tonight's living room in spite of the fact that he's on vacation and take some time out, as opposed to having to reschedule. So a big welcome to Dr. Hogarth. Before I ask him to introduce himself and tell us a little bit about him and how lung cancer became an area of focus for him, I want to give a huge shout out and thank you to everyone watching who may have participated in our Voices Advocacy Summit over the last couple of days. Storming the Hill virtually was a new space for all of us, and I think it went beautifully, and we are so grateful for your support in coming out and supporting us in that effort. If you weren't able to support us, there's always next year. So again, great job, everybody. Thank you. So with that, I'm going to ask Dr. Hogarth before we jump into tonight's topic, which is pulmonology and managing multiple lung nodules, to give us a quick hello and tell us who he is and why lung cancer is important to him.
Hey, thanks so much for having me. Hear me okay? Though apparently my video is horrible, so I'm going to turn it off for a second. And maybe then the sound will be better. So, I'm going to apologize to everybody. When I was setting all this up, I was this before. There was terrific Wi-Fi signal, and then quite variable. You can hear me okay?
Yeah, we can hear you.
Okay, well, good. I'm honestly not video. So you asked what I do. I run the bronchoscopy program at the university. Hey, there's a screenshot. Terrific.
There you
So I
go.
run the bronchoscopy program at University of Chicago and have obviously been working in this field for some time and actively, like everybody on this call, lung cancer is the reason I get up in the morning. It's the reason why I'm here on a trip with my family and I'm on this call because the fight never ends and it's unbelievably important to me. It has affected friends and has affected my friends' family members, and then obviously all of my patients. So thank you for this opportunity. Obviously, when we originally planned this, I was actually supposed to be live there with you.
You were.
And I guess COVID had some different plans. And so instead, I'm here with you virtually.
It did, and we appreciate it. For sure, we'll have you back in California in our live studio here with an
Please,
audience
I would love
as
that.
soon as we can. No, we would love to have you. And for those of you who may or may not know Dr. Hogarth, we did a regional living room in Chicago a couple of years ago now, and Dr. Hogarth was on our panel there. So he is no stranger to this platform. And again, welcome and thank you for joining. So I want to jump into discussion. I know this is also we're limited in time. We only have an hour during these virtual meetings. So I want to make sure that we cover all of the important things that we're going to cover today. So we're going to go ahead and jump in.
Okay.
But before we jump into the discussion about managing lung nodules and then move on to pulmonology as a whole, I want to do a little bit of explaining to the folks who may be watching about what exactly lung nodules are.
Sure.
I know I've read and learned along the way that by the age of 50, around 50% of adults will have lung nodules, and that a large majority, upwards of 95% of those, are not cancerous. So, can we talk a little bit about what a lung nodule is? Some of the features and so on, starting with well, let's just jump into what a lung nodule is, and
Sure.
then I can ask questions along the way.
Sure. No. So it's a description first, right? It's a radiologic description. So on a CAT scan, someone will there's sort of the broad spectrum of black and white. So air, most of what the lung is, will show up black on a CAT scan. Things like that are bone will be bright white, and then the various grays in between represent all the other tissues. Your lung should just basically be, at least on a CAT scan, mostly air and some blood vessels. And that's what we expect to see when we do a normal CT scan on somebody. When we see something in that space that shouldn't be there, it is then characterized as a nodule. If it's under the size of 3 centimeters, if it's bigger than that, it actually gets called a mass. But it represents something solid because the lung is very sort of spongy, mostly air filled. And so a nodule solid. And of course, a nodule can be many things. That's where everyone's concerns begin because, of course, a nodule, God forbid, could, of course, be cancer. But like you said, majority of nodules that we find on the general population and even a high risk population, if they are small, they generally are not cancer. Distinguishing, of course, between the two is the question, right? And that's a lot of what I do, and many people like myself spend a lot of time doing, deciding on what's the best course with our patients together to help sort out what these things are. The
That's
problem
great.
is that
Oh, go ahead.
the
Sorry.
problem is that your lung, no, it's okay. The problem is your lung scars, like everything else. So if you, the best way I can describe it, if you got a cut, you have a little wound on your arm and it was deep enough. Let's say you got stitches, you have a scar there for forever, right? Well, your lung will scar similarly from infections and other things that have insulted the lung, if you will, and it leaves a mark. But the problem is it's not always easy to tell one from the other. And so a lot of times that's all a nodule is a scar.
That's great. So when we are looking at lung nodules, there are different features. Can you talk a little bit about what some of those features are? Margins, density, size, consistency. I know a lot of times patients, especially those patients that are very active in their healthcare, will receive copies of their CAT scan reports, and it will explain things like, or say things like spiculated, ground glass. Can you explain a little bit what some of these differences are in nodules?
Absolutely. So, not you're writing in characteristics on the CAT scan. So you're always going to start with its size, and you're going to start also with so is it smooth and round, like a marble, or is it when you say the word spiculated? That's where it looks almost like a starburst, and there's sort of pointed rays coming off of it. You will describe whether there's calcium in it or not. You'll describe its density. Each of these various characteristics raise and lower the probability of cancer. And so ultimately, when it comes to a nodule, there are no absolutes in the sense that you can look at one nodule with 100% certain abilities.
Oops, sorry, Kyle, I think we lost you for a second.
I'm so sorry. Can
No,
you hear me now?
that's okay. I can hear you better now. Yep, there you go.
Okay. It is a larger spiculated nodule, for example, very concerning for cancer, but not a guarantee that it's a cancer. So it's always about probabilities of malignancy that raise or lower our concerns with our patients. Because, for example, if it's smaller, well, chance of malignancy is beyond remote. Not zero, but beyond. We're a lot.
Oh, sorry, folks, we're having some audio issues.
It's my fault. It's 100% fault.
No. Can you hear me?
I'm sorry?
Can you hear me?
Can you hear me?
Yeah. Yeah, I can hear you
I can
now.
hear you.
Yes. This is like one of those commercials. Can you hear me? Can you hear me? No, it's
Exactly.
totally fine.
Can you hear me? Can you hear me?
If for some reason, just FYI, I repeat a question, it's because you broke off. So what I think I heard you saying was that nothing is definitive. There are certain features of nodules that will lead you to define it as maybe more suspicious for a malignancy versus something else. So
Everybody go in the fucking dining room.
when you are
Can you hear me?
looking at these nodules, yeah, I can hear you.
I'm going to try moving to a different spot.
Sure.
We'll see if this helps improve things. Is it better now?
Yeah, I can hear you.
Wonderful.
Listen, in this day and age, nothing is shocking or surprising to everyone. We all need to be flexible in.
I know. I just apologize. I try to set a standard. I try to set a standard for myself, and I'm failing miserably.
I know. And for those of you, no, you're not failing miserably. For those of you listening, about an hour prior to showtime, Dr. Hogarth signed in with the team managing the back end, found a nice spot up on this mountain where he had great service. And then, of course, 5 minutes before go time, he lost his service. So he had to make a quick switch. And we are, again, so grateful that that you're even making the effort tonight for us. So
Okay.
what I was saying was you've talked a little bit about some of the features. The margins are either spiculated, with the pointy sort of edges, smooth, more like a softball, I guess, or lobulated with more sort of cloud-like, sort of shaped edges. You talked about
Right.
density, size, consistency, a little bit, whether they're solid or partially solid or ground glass. So and you mentioned that, there are some things you look for that may sort of lend itself towards being more suspicious, but most definitely does not always mean that it's a malignancy. What are some of those things that might make it look more suspicious or need further evaluation?
Size, the bigger, always more concerning. The speculations, like you talked about. Um, Also, the patient's history. So, if there is a prior cancer history that you're always a little more worried, and that's cancer anywhere. Is a nodule, we already said, it doesn't have to be cancer, but even if it is malignant, doesn't have to be lung cancer, although that's obviously always our concern and focus.
Sure.
And so it could be a cancer from someplace else. And so size and the speculations are probably the two biggest things. Put in again with that person's history, their smoking history, though of course clearly non-smokers are at risk as well. Their family history, and then additional tests that can sometimes help. So things like a PET scan, though a PET scan is in no way, shape, or form definitive for cancer either, because things that are inflammatory will be positive on a PET scan. The way that I've heard this best described, a colleague of mine, Doug Ehrenberg at Michigan, describes it as a sort of a dial, and how more concerned or less concerned am I? When I look at a nodule, if someone tells me, "Hey, I have this CAT scan and there's a nodule on it," but then they're able to pull up an image from, like, say, a year ago where they had another CAT scan for whatever reason, and we can see it, and in 1 year it has not changed at all, I'm a lot less worried. Not zero worried, but less worried. If it has gotten bigger over a period of time, again, now I'm more worried. Not definitive, but going to influence the discussion I have with you. And like I said, the reason I'm glad to do things like this, and for any patient on the line, you have to definitely ask probative questions and ask important ones like, what's the probability that this is malignant or not? What do I need to do up or down to be concerned?
So that kind of leads into the sort of the management part of, and also what happens next if you see something suspicious. And you talked a little bit about the sort of watch and wait, like, well, I'm wherever you are on that dial. If you're below the 5, if it's a 1 to 10 dial, right, maybe it's a watch and wait
Right.
to see what happens next. At what point does it take that next step and move on from something suspicious to something that maybe we need to look a little deeper at and grab a biopsy?
I would argue, I guess it's a moving target. And the reason I say that is that it's partly the physician in their sense of what the risk is for this nodule being malignant. Part of it's clearly the patient. We all have to have a frank discussion of what's the chance it's cancer versus also when I have to start doing invasive procedures of any kind, those come at risk of pain and suffering and, God forbid, complications.
Right.
So it's a discussion, right? And so I can tell you, hey, there's only a 2% chance it's cancer. Now, to me, that's worth taking at least a short-term follow-up. And I think what everyone needs to understand is, someone says, hey, we're, quote, watch and wait, that doesn't actually mean we're doing nothing. That means instead we're actually trying to protect you from people like me. In other words, I'll be glad to put scopes inside you and poke and prod at you, but why would I do that if the chance of cancer is so low? I'm, jokingly trying to you from me. But if I instead say to you, look, there's about a 20% chance this is cancer. Well, some people, maybe with that, me as your advising physician, I'm not comfortable with those odds. I want to know if it is or not. Now, look, there's other things that weigh into this, because depending on what procedure is going to be offered or what procedures are available, you may not be able to have a less invasive procedure, or maybe you have multiple other medical conditions that make this 20% chance not, none of us like it, but maybe doing a procedure on you is dangerous because of your heart condition or how bad your emphysema is or whatever. It doesn't. The problem, I think, that everyone has faced in nodule management in general is that there really isn't a one size fits all, and is as unique as every single person on this, conference is. That's the uniqueness on the approach as well, and that's why you always want to be being evaluated by somebody who does this for a living, who focuses on lung nodules, lung nodule management, lung cancer management, like taking biopsies of the lung. It's not someone who is a dabbler, but someone who does it full time.
That's really, really great advice and information. Dr. Hogarth, when we talk about, because quite often when patients do get, a CT scan, or, pulmonary nodules are found incidentally. In other words, they,
Yeah.
God forbid, got in a car accident and had a CT scan, and all of a sudden, everything looks great. You don't have a broken back, but we spotted some of these nodules. When we're talking about, and it's not always just one nodule. So when we're talking about multiple lung
I have two.
nodules, oh,
I have two.
do you?
I have two nodules. Oh yeah. CAT scan for
Yeah.
no reason.
Yeah, yeah. So when you are looking at these multiple nodules and you talk about management of these nodules, what does that mean?
Well, so it's a great question. Multiple nodules is definitely a different discussion than the single pulmonary nodule. You're concerned that one nodule is present, and is that a lung cancer or not?
Hmm.
Multiple nodules is a broader thought process in that definitely someone could have two different cancers developing. Let's start with define the word multiple. Let's say there's just two nodules. Okay, well, that could be two separate lung cancers developing. That's one possibility. It could be a lung cancer that has spread within the lung to another part of the lung. That's another possibility. From somewhere else in the body. It doesn't have to. It could be multiple scars. Mine are scars, 100% scars, because I got follow-up scans and showed they didn't grow. So, for as an example, and I can tell you where they came from. I had pneumonia twice, and there they are. So, but there are other diseases. The rheumatologic diseases can lead to nodules in the lungs. I think always the first take-home message, you said it at the beginning, is that a majority of lung nodules found are not cancerous. And that's a good place to start every conversation. That doesn't mean we're not worried about our patients. That doesn't mean we're ignoring your concerns. But at the beginning, what we're always starting with is, thankfully, a majority of nodules found are not cancerous. And let's explore what they could be. Depending on where you live, there are a lot of fungal infections that look just like a cancer. In my neck of the woods, we have a lot of histoplasmosis and blastomycosis. And we have a lot of patients that go to the Southwest and then pick up coccidiomycosis. They present PET positive spiculated nodules. They look just like a lung cancer. You can understand why people would be concerned, but you just want to make sure it's not that.
And the only way, I guess, to determine that would be to biopsy?
Well, so thankfully there's
Go ahead.
a fungus infection. Well, actually, there's
Yeah.
this is where the other great advances that have been going on. So the other bit of good news for a lot of our patients, besides all the advances in CAT scans and better ability to see inside the body, better technologies in Bronchoscopy, and of course way better therapies if someone does need therapy for cancer. We also have better and better tools to help us. So going back to the single pulmonary nodule, there are several blood-based tests that can help to risk stratify, not just based on your CAT scan, but also based on how your body is responding to what's going on inside. In other words, if that is a cancer, there's a sort of signal, if you will, that your body is giving off, and we can start to measure that. If it's something infectious, there's a different signal he's giving off. And these tests aren't perfect, but they raise and lower that risk, that needle. I'll give you a perfect example. I had a patient who came to, based on what his CAT scan looked like, based on his smoking history, we had calculated out that he had a 45% chance that the nodule was cancer, which obviously scared him, scared me, scared all of us. But he also was a very good case, like just from his medical history. So these blood-based tests, and it turned out risk of cancer was actually 6%. Now, that's not zero, but 6% means he has to get a follow-up CAT scan. And on follow-up CAT scan, the nodule went away. And so he avoided a procedure. 45% risk is not one that I'm comfortable sitting on. But 6% is something that we talked about together that was comfortable for watch and wait. And that newer technology, this one blood test has only been available for less than a year. There's also blood tests to look for your body making antibodies to these various infections. And so there's a lot of other things that we have at disposal that we do long before we start talking about taking biopsies to figure things out.
So you talk about this blood-based, risk stratification test. I mean, is that something that is done on all patients? And if it's not, is it something patients should be having conversations with their physicians about
Yes.
during this
So
process?
it's a relatively new test, and there's many others under development, and so there's thankfully going to be a selection of choices, if you will. It's relatively new. Many physicians may not know about these tests availability, but it's a blood draw. There are, of course, various exclusions. If you've had a prior cancer history, these tests have not been validated, so they are done in someone who has a lung nodule that is indeterminate. We don't know what it is, but does not have a cancer history. That's how we. But again, they're not perfect because they don't say 100%. They don't say 0%. And in some cases, there isn't enough of a signal, and they say they don't really change the risk. So but they're one more tool in that decision tree, the physician and the patient. What's going to be our course of action? What I always warn all my patients about is that, let's say you come to see me and I say to you, there's a 6% chance it's cancer. I think we should get a follow-up scan. We should not do a biopsy. And you go see another doctor and he'll say the same thing. And then you'll go see someone else and she'll say the same thing. But if you keep looking, you will find someone willing to operate on you at some point. And then, of course, they will have proved it was benign. You will have gone through an unnecessary surgical procedure. If you hunt long and hard, you will find someone willing to, do a procedure that you don't need. So just be cautious, and again, watch and wait. It does not mean goodbye, never see you again. And quite honestly, frequently, a majority of the time when we get a follow-up scan, it's 3 months after the original scan. But depending on when the patient's scan was done, and then they see their doctor and their doctor sends them to another doctor, that scan already may be a month old. And so, waiting an additional 2 months, the even if it's a cancer for these small nodules, their rate of growth and their risk of spread is so low that we are not harming you in the off chance it's a cancer. But what we are doing is protecting you from unnecessary procedures. And that's what these blood tests do as well.
So I think it's
Does
really
that make
important
sense?
because, yeah, no, it makes perfect sense. I think sort of one of the things that, to me seems like such a shame is quite often when patients are told, that a nodule has been found, this type of conversation hasn't happened with their physician in order to help
Correct.
to sort of quell their fears, right? So I go get a CT scan, somebody tells me they see something in, one of my lobes that's not supposed to be there. Come back in 3 months, end of story. I'm going home and
Right.
panicking. You know what I mean? So
Absolutely.
so what would you recommend maybe patients whose physicians aren't having that conversation? How do they sort of start that conversation? And what questions should they be asking their physician to help sort of quell those fears?
So there are. Let's start with some of the basics. They should one, if ask their physician, are you a specialist in this area? So like if it's your general practitioner, they're not a specialist in lung nodules and lung cancer. They are just following a set of guidelines. But you know what? Those guidelines, the various guidelines that have been written to help guide physicians in this decision tree, were developed precisely so that we don't take people for both unnecessary procedures, but also unnecessary repetitive scans, right? We used to scan people every 2 to 3 months. And for some nodules that are so small, the guidelines tell you not to even be scanned for another year. That was not some arbitrary decision. That came out through good research. And what that also does then for patients is helps you to avoid in 1 year getting 4 to 8 CT scans. That's a lot of radiation. You may not have any lung cancer, but if I CT scan you enough, I could give you one, God forbid, right? And
Mm-hmm.
so part of this discussion, I think, is you as a patient to say, well, why are you telling me 3 months? Like, what's your basis of that decision? And they'll say, well, look, there's these online nodule calculators. We plugged in the characteristics of you and your nodule, and it shows us it's a 2% chance it's cancer. 2%, that's not, you can't, too small to biopsy, et cetera, et cetera. That's why we're going to follow it. That's not a very long conversation, but it's a conversation. And you as the consumer should have that conversation. And if your physician's not willing, find a specialist in lung nodules. It typically are a pulmonologist, and have a discussion with them about this.
Yeah, that makes great sense. Thank you. One question we get asked often
Be
by
informed,
patients.
right? Be informed.
Be informed and have those conversations. I mean, it's your right as a patient to have your questions answered, especially when you're told,
Yeah,
you have a 6%. Yesterday, I had a 0% chance of having a cancer, and now I have a
right,
6%. You know what I mean? So, or
right.
5 minutes ago, it was
Well, and
zero.
last time
So,
I
I mean,
checked, you're the customer.
yeah, yeah. Like I said, I'll reiterate that I think it's a shame because it's quite often that I hear that that's not the case. And those are the phone calls we get. How worried should I be? Because, maybe their physician didn't have that conversation with them for whatever reason. So really
Well,
great information.
I'll give you an example. Let's
Mhm.
assume that it comes back as a relatively low risk, and we do watch and wait. And on the follow-up scan, it grows another 2 or 3 millimeters, let's say. Now, the risk for cancer just went up, but still not to 100% because benign things grow as well. But now we're both worried. I'm more worried. You're more worried. But the good
Right.
news is, God forbid that's cancer. It was stage 1 when I met you, and it's still stage 1 3 months later. We've not
Yeah.
lost anything as far as helping you. But what we've gained is all the people who avoided unnecessary procedures.
Yeah, that's a great point. That 3 month time frame, could be a win in that it just stays stable and it's nothing really to worry about. But even if it
Right.
does grow a little bit, you're not any. I hate to use the term worse off, but any worse off than you were 3 months prior to that.
No, I mean,
One of
but that is the right term to use. I mean, I understand it's nobody wants to have that diagnosis ever, and I think we should
right,
make one real clear point for all our listeners. We're talking about a CT scan that the only thing present is a lung nodule. That is different than if your CAT scan report says a lung nodule and also one of the lymph nodes in the middle of your chest is enlarged. That is never a watch and wait. If there's an enlarged lymph node, that needs to be biopsied, and it needs to be biopsied right away. We do not watch and wait lymph nodes, with some rare exceptions. But if someone tells me there's a nodule and a lymph node, that lymph node needs a biopsy, and it needs it soon. So this is
gotcha,
all people whose CT reports only say nodule.
gotcha. So it would not, gotcha. But the CT reports, if it had any lymph node involvement, it would also say that on the report.
It would.
Correct.
What would happen is they would
Yeah.
say there's a nodule X, whatever size and whatever lobe, and the whichever side the nodule is on, that hilar lymph node is enlarged at 14 millimeters, let's say.
Yeah.
Well,
Yeah.
that lymph node should not be enlarged, and
Yeah.
if it's enlarged, it doesn't, of course. So I just want to clarify, because that's a completely different discussion. That's
Yeah.
not a discussion
No.
of a nodule anymore. That's a discussion of an enlarged lymph node. But that's important because a lot of times people only talk about the nodule, but when you read in the report, they talk about enlarged lymph nodes. That needs to always be evaluated.
Yeah. And patients, that don't probably should hang on to these reports.
Definitely.
And yeah, and be able to go back and look at them, especially as you're following. If you're following a patient and doing CTs, every 3 months or 6 months or even every year, to be able for your own sort of, education, about what's going on, be able to look at them and understand that. I have a question. Does it matter? And I've had patients ask this before. Does it matter whether or not the same machine, for example, is being used for that patient's PET scan or CT scan? Are they calibrated differently? Is it important?
It's a great question. It's not so much the same machine. There are subtle differences between brands, if you will. The one place may have a certain brand, but there are profound differences in how a CT scan is processed, and that has nothing to do with the brand of the scanner. That has to do with the protocols that are used by the radiologist in that radiology center. So frequently what happens at my own institution, and the guidelines are that everybody's CT scan of their chest should be essentially a 1 millimeter slice thickness. So that means that's high resolution, 1 millimeter or less, and continuously sliced. What many people don't know is that you'll get a CAT scan at a center that uses what are called 3 millimeter cuts, and those are thicker. But that 3 millimeter cut is a lot of averaging, and depending on where the next scan is done, a nodule that was only a few millimeters because it cut across two of these 3 millimeter cuts, the patient's it's ever so slightly different, but now it shows up on three separate cuts, and so now the radiologist officially has to call it bigger, but it's actually not bigger. And so, because it's just the yardstick you're using, if you will. So, one of the very important things is to try to be consistent with where you get your scans. So, not necessarily the scanner, but the center, so that you're truly comparing apples to apples. But again, if you get that incidental scan found, and they were scanning your abdomen for kidney stones, and they find a nodule in your chest, when you go to get that follow-up scan that's going to be dedicated to your chest, you want to get it at a center that, again, has experience with lung nodules. You're going to get the same radiation. Actually, you're going to get less, because the better scanners do the thinner cuts, but they do it with less radiation. So you're going to get less radiation and quite literally get more bang for your buck. And you're going to get more data for you and the physician to truly quantify your cancer risk, which is the only reason you're here. And there's still centers that do 5 millimeter cuts. That's like honestly looking at the television you used to have 30 years ago and comparing it to the one that you're probably looking at right now.
Yeah. Yeah, I think that's such important information for folks to know, because like I said, I've talked to several patients over the last, over a decade that, have had concerns and, lost sleep over something that turned out to be, we rescanned you, the way we scanned you before, and now there's no growth, right? So,
Correct.
so really, really, really important information.
So
You mentioned a little. Oh,
I'll
go
make
ahead.
it. If something goes from 5 to 6 millimeters, but I'm using a 3 millimeter ruler, how I can't make that statement, right?
Yeah, yeah, yeah. Do all? I mean, obviously, this is a well-known thing. Is that something that's taken into consideration when repeat scans are when appointments are being made for these repeat scans, or is it something that maybe just kind
I
of?
wish it has to do,
Yeah,
honestly. It's protocol driven, and it's driven by the radiologist. So the original Fleishner Society guidelines were written by our thoracic chief of radiology, and what it meant when we started switching our protocol over a decade ago was that they had over 300 images to look at. And that's a lot of work for the radiologist. The quote industry standard was to look at 90, so they were quadrupling their work, and
yeah,
they did it because they knew it was better for the patients. But sadly, that's not what everybody does. And
yeah,
again, that's I have this conversation frequently with my parents who live nowhere near any major cities,
yeah,
and they'll say, "Well, I'll just go to this place down the street. It's so convenient." And I've seen the place down the street. It may be convenient, but that doesn't mean it's providing good care. And
yeah,
so, when it comes to something as important as may I have lung cancer or not, go to a place that has experience with lung nodules and was going to do your CAT scan correctly. It's
yeah,
worth the extra drive for that one
yeah.
time.
Yeah, gosh, it just makes so much sense to me, and I think probably for a lot of people that are either watching live or will come back and watch this post live, it's going to be a big aha moment for them. So
Yeah.
I'm glad we were able
And
to.
again, I'm not asking you to go to see that doctor every week, and you're going to have to drive hours and hours. It's once, and hopefully, when you get good news, it is only once.
Yeah,
And God forbid, it isn't. Are you honestly going to put your well-being on the issue of whether or not you had to drive an extra hour or two, or go into a city if you're, not, or whatever? It's
yeah.
worth it because it's your health.
Yeah, no, I couldn't agree with you more. And I know that to your point about your folks and where they live, I mean, there's a lot of people in this country that live in more rural areas, right? I mean,
Yeah.
there's a ton of disparities and socioeconomic issues. I mean, you name it, right? That may not,
Yes. Correct.
readily allow education on this topic, or B, for it to be easy for a patient to access this good quality care. But I know that at Go To Foundation, we've got sites around the country that we work with. So we
Yep.
fortunately are able to help a lot of folks get to these quality centers.
And so that everybody's aware, you don't have to always be in a big city. There are some
Yeah.
very excellent centers in very small towns. There's
Yeah.
wide variability, and it's this is the foundation for lung cancer, but every nodule has that potential to be that. So if you've got friends and families that have been told they've had an abnormal CT scan, this is definitively the starting point for you from a resource perspective.
Mhm. So a question about, we talked about, multiple nodules, maybe one is cancerous, one isn't. Maybe they're two different cancers. If you're looking at, like I said, multiple nodules on a CT scan, does this same sort of thought process apply for a patient who maybe has been living with lung cancer for the last 4 or 5 years, and then, a new nodule pops up? Is that still if it's very small, doesn't look super suspicious, are you still managing it the same way? Or are you leaning more towards it
What
being some sort of metastatic disease?
No, what a great question. What a great question. So,
Mm-hmm.
we'll take a lung cancer survivor who had surgery, cured, free of disease, active surveillance, and then suddenly a new nodule pops up, 4 years
Mm-hmm.
afterwards.
Mm-hmm.
Obviously, everyone is terrified, patient first and everybody else, but it's
Mm-hmm.
a 7 millimeter nodule. And it wasn't there a year ago because let's say they're far enough out that they're not getting scanned every 3 months. So a 7 millimeter nodule, and a lot of the some of the tests I was talking about, those are not validated. They're not validated in a cancer survivor. But when you still plug in just generally, what's the risk of this? You look again. What's the nodule size? What are the nodule's characteristics? We're going to do a short-term follow-up scan if it's that small, for example, because even in that patient, the further you get out from your first diagnosis of cancer and then undergo a curative intent resection, for example, the once you're 2 years out from that surgery, your probability of malignancy goes down a lot. Thank goodness. And so another nodule shows up. Yes, we're worried, but nor should we go charging in and start cutting out a significant amount of lung. We get a short-term follow-up scan if the nodule's small. Now, it's been a year since we scanned you and you have something fairly large. We're going to have a discussion, right? I think what also ends up framing a lot of these discussions is what's the level of invasiveness we're going to have to do in order to tease out what this is, right? If this is a nodule that we can easily get to with one of our bronchoscopy devices, well, that's minimally invasive, straightforward. We'll figure out what this is and put the issue to rest one way or the other.
Yeah.
Well, that's very beneficial for the patient. But if they're fairly small, our ability to successfully biopsy them is actually quite limited. And honestly, the super small ones should be watched because even in a high risk patient, majority of these are still going to not be malignant.
Interesting. I know with some of you watching may or may not know, if depending upon how new you are to the living room, that Bonnie Adario, co-founder and chair of GoTo, is my mom. And I know she was diagnosed in 2003. And so she's obviously, 17 years out from her original stage 3B diagnosis. But she has nodules. She still gets scanned, annually, and she has nodules that they've been watching for, a better part of a decade now. So that's just one example of
No, and
kind of what we're talking about.
it's scary. It's understandable. Every one of my patients, when it's time for that annual scan, walks in with a deep breath, holds it for a couple of minutes until we can go through the results together. And then they finally can breathe that sigh of relief of either stability or no nodule. And I can't directly appreciate it, but I can see it in my patients' faces. And that's why, again, it's so important to be working with someone who you can talk to, who you can work with, who will listen to what your concerns are, and either run with those concerns and let's do what needs to be done for you, or help try to get you to, be able to see that the probabilities here are quite low and let's avoid doing invasive things to people. if they don't need it,
Yeah.
obviously.
Yeah.
I always
Yeah.
tell all
No.
my patients too, I start very aggressive. I'm in my mind, I am very aggressive about nodules. So I tell them this so that when I say let's watch and wait, they need to understand where I'm coming from. I'm coming from a go, go, go position. And if I'm saying whoa, 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 that means a lot.
Yeah. Yeah. And I mean, my greatest wish is that all patients in this type of scenario, had a physician like you who was relatable, and I guess, someone that was easy to talk to and help to, to calm some of those fears when necessary, and to walk through, next steps when maybe those
Yeah,
next steps need to be taken. So we've got about 12 minutes or so left before I have to do some closing end of show, and I want to spend a little bit of time talking about your role um, on a multidisciplinary team, specific to a lung cancer patient, because I think quite often, it makes. I tend to be a logical thinker, so if it makes good logic sense to me, I'm like, why wouldn't it make sense to everybody
absolutely.
else? Um, but I think, quite often patients, in treatment for lung cancer don't have a pulmonologist that they see on a regular basis and on their team. Can you talk a little bit about why that's important and what role you play in the
Sure.
ongoing treatment of a lung cancer patient?
Absolutely. So, understandably, if you've been diagnosed with lung cancer at whatever stage, it becomes an all consuming process. But what I often, unfortunately, frequently see, the rest of your body doesn't like go on pause. So your blood pressure still needs to be controlled, for example. If you have underlying COPD, we need to be treating that, because the last thing I want you to do is get a pneumonia or an exacerbation. That's only going to make things worse while you're going through on your journey with lung cancer. It's easy to lose focus on everything else. Understandably, lung cancer becomes the focus, but it actually does you well to have another member of your team who's not the person in charge of chemotherapies or immunotherapies. I don't prescribe those things. I'm in charge of your
Right,
lungs. I'm the person who's
right,
there to help make sure you're breathing well, and your internist
right,
is there to make sure that, by the way, that you haven't been screened for colon cancer in 2 years, 5 years, whatever. We don't want to go through everything you're going to be going through and then to have something sneak up on us that we could have nipped in the bud from the beginning. There are, of course, for all the great advances we've had, there are, of course, side effects and complications with the various interventions and drugs. You need to talk to, the radiation oncologist or your oncologist. But if it's affecting your breathing, your pulmonologist is involved. If you had a surgery and there's issues with your wound, your surgeon needs to be involved. And that is the whole idea of the multidisciplinary team. When it comes to lung cancer and lung cancer survival, it does indeed take a village, and that village is all the specialties that are involved in lung cancer. Everybody needs to be at that table, even if you're not always physically seeing them. What I always tell all my patients when I make a lung cancer diagnosis and say, okay, tumor board, meets in 3 days, and basically, even though you're not going to physically see everybody, everyone's going to see you, virtually, if you will, and review everything. And we're going to come up with the best possible plan with everyone's input as to how we're going to help you beat this. And that's the only way to move forward. You patients absolutely have to be cared for by a multidisciplinary team.
I could not agree more. And I think I remember this early, even though it was back in 2003 and 2004, really when my mom's treatment started, she had a pulmonologist who played a very active role throughout the process. And it was shocking to me to find, as I began to work in this space, that people didn't. And things like pulmonary function tests, right, to
Right.
see where you are, and is that changing over the course of your treatment, and what type of support might a patient need based on what their pulmonary function looks like. And I think one of the ones that's quite often missed, and I think is a really important one, and will continue to be, especially as screening becomes more prevalent and folks are having lobes removed or surgeries because their surgery was found early stage. That will have a direct effect on your pulmonary function and what it looks like, because you're now short a
Absolutely.
lobe, right? But one of the things I found really interesting, and we unfortunately didn't find it out with my mom until we were in a situation that it became relevant, and that was an altitude test to determine how her lungs function at certain altitudes. And,
Yeah.
whether it be her home in Tahoe that sits about 6,000 feet, or quite honestly, even for those who don't think that altitude's an issue, but maybe traveling long distance on airplanes, need to know that planes are pressurized at between 6 and 8,000 feet. So if you have trouble
Right.
breathing at that altitude, it's important that you know that as you get on a plane, right?
It's all the little things. It's you need somebody, you need your internist and you need your pulmonologist for the two people that are still very much on your side, but are not there battling cancer directly. Because again, I don't prescribe any of these drugs. I'm there
Right,
battling for the rest of you. Right.
right,
And I think that goes
right.
in hand. The other reason to have this multidisciplinary team, if you are found to be an early stage cancer, but let's say you have some various comorbid conditions, heart disease, lung disease, etc., very frequently people are told they're not a surgical candidate. Get a second opinion by a person who only does thoracic surgery. There are general surgeons who should not be anywhere near your chest on the inside, and yet frequently that is still the case. And then there are cardiothoracic surgeons who spend 90% of their time working on hearts and 10% of their time working on lungs. And then there are dedicated thoracic surgeons who have had extra training only and solely dealing with lungs and lung cancer. And as you can imagine, patients' outcomes are very much tied to that level of experience. I am fortunate and blessed. I work with 3 thoracic surgeons who are spectacular. I have, if they ever tell my patients they're not able to have an operation, there's not even a debate. Then it unfortunately means they're not able to have an operation, because if these
Yeah,
folks can't do it, no one can. And it's that's
yeah.
and that's there. And thankfully, there are people like this all over the country.
Yeah, no, I think that's a really great point. We had a brief discussion about it during a panel presentation at our Voices Advocacy Summit yesterday, about the
Good.
importance of knowing who is doing your surgery, and the importance of
And your
having a
bronchoscopy.
yeah, yeah, exactly. No, it's very, 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 very true. Um, so we've got a couple of more minutes. Is there anything else that you want to touch on or focus on, or that you think is really important for the folks watching to know before we sign off and close out?
I think I'll probably just to, and I'll be partially repetitive, but remember, when you've been told you have a nodule, start off with the fact that though cancer's on the list, it is not a guarantee that that's what it is. So take a deep breath and be thorough in your approach to it. It's understandably that the first reaction is panic. That's what mine was. I got told I had 2 nodules. My brain went right to the lung cancer picture. And then I paused, reviewed my scan, and took a deep breath and realized what the chances were, etc., and had a thoughtful approach, with a colleague who managed me to make sure it was fine, and avoided unnecessary procedures. If you're going to need a procedure, make sure that it's been justified as to why you need it. What is the probability that this is malignant? What's the probability that the procedure is going to be diagnostic? What is the probability of complications from that procedure? Are there non-invasive means to figure that out through blood tests, etc.? Be an active consumer so that before you're laying on any form of a table to have a bronchoscopy or a needle biopsy or a surgery, that you have a complete understanding as to why you're there laying on that table having that procedure. And if you can't tell me why you're laying there, then your physician has not done a good job of explaining to you the real risk for this to be malignant and we're trying to accomplish today.
That's great, Dr. Hogarth. Thank you so much. I want to close out, or before we close out, I want to finish with a couple of questions that came in
Sure.
from some online folks. Um, you talked a little bit about, maybe you have a single pulmonary nodule, but also a lymph node. This person is asking about nodule or nodules on both sides. So if it
Yeah.
crosses over the mediastinum, what does that look like?
Well, so if there's 2 nodules and they're on, in both lungs, it's the same still possibility that each one is an individual lung cancer. One's a lung cancer, one's not, or it's a lung cancer that is spread to the other side, and all of those clearly mean very, very different things. What ends up happening? Each individual nodule. So if you have had no history and you've been told you have 2 nodules, then we assess the risk of each nodule based on the individual characteristics of that nodule. So if one's 6 millimeters, very low risk, right? The other is 1.4 centimeters, higher concern, and it's spiculated, and et cetera, et cetera. Okay, the 1.41, you and I are going to have a discussion about doing a biopsy. The 6 millimeter one, we're going to follow that. So we're going to have a procedure on the one, watch and wait on the other.
Great. So another question, you talked a little bit about inflammation, and if a patient's told it's inflammation and to come back in X time for a repeat CT scan, and they're still told inflammation, how long do you look at inflammation before you think, well, maybe it's not inflammation?
Right. So I guess what I would say is it would depend on what they're calling inflammation. And what I mean by that is on a CT scan, sometimes the word inflammation is used when in reality what they should be describing is something called a ground glass opacity. Now, usually most radiologists can make that distinction pretty clearly. And a persistent ground glass opacity, that's actually a completely different discussion because that's separate from a pulmonary nodule. And there's a different set of guidelines and follow-up for those. And I'm sure you've had a living room on this. But if a ground glass thing starts to become more solid, that's extremely concerning. That's actually probably one of the most concerning findings of a ground glass density on a follow-up scan becoming more solid, more dense. But when people ask, well, why was there inflammation? So, you have all these little airways. If one of those gets filled with a little bit of mucus, then the area behind it can become inflamed and think of it almost as a mini pneumonia. It's not what it really is, but you can frame it in your brain that way. Really tiny, but again, on a CAT scan, it will show up as something solid because the lung should be mostly filled with air. And if it's filled with a little bit of mucus or a little bit of pus, it will look more solid because part of the lung around that will close down. And so the radiologist can only call what they see, and they have to describe what they see. I will point out, when we talk about describe what they see, so radiologists will use some specific words, but a pulmonologist has to see your scan. So if you come to see your lung doctor with a new CAT scan finding and you've had your scan done at a different hospital, you must bring the actual images. So usually it's on a disc. The report is not good enough. We need to visualize and view the nodule. We look at them differently than our radiology colleagues. It's complementary in the view. So please always, so when you said earlier, keep a report, I will tell you if you've had a CAT scan someplace, get the disc burned.
That's great.
Because
Great advice.
unfortunately, even with electronic medical records having some level of being able to be shared between some medical centers where, hospital system X can see some of the reports and why, what we can't ever see is the actual images. Those still, sadly, have to be burned onto a CD or a DVD. It's ridiculous, but that's how it is.
Gotcha. And then a final question. What role, if any, does a pulmonologist play in managing innumerable small nodules? Or is that more of a medical oncologist?
Well, it depends. So if there's numerous small nodules, again, would be what are they from? So, if there's literally, well, they'll say they're too numerous to count. There's hundreds of micronodules within the lungs. Depending on the clinical scenario, again, there's a decent chance that those actually aren't malignant. Now, there's certain cancers that if they spread to the lung, this can be a pattern they have. So if someone told me they had a history recently of thyroid cancer or breast cancer and now have hundreds of nodules in their lung, I'm very worried that that's what those are. So we would pursue a biopsy to prove it's not those, that it could be something else. So again, nodules always have to be put into the clinical context of the patient's history, and not just not just a smoking history, a history of your health. Are you up to date on all your other screens? So, sadly, what sometimes happens is that I'm the person who diagnoses breast cancer because you come to me with lung nodules and then you haven't had a mammogram in however long, and God forbid, and lo and behold, we'll do a breast exam. We find a breast mass, and then unfortunately, then we know what all those nodules are. So it's nodules without a clinical context are always concerning. And then again, that raise and lower my concern of any form of cancer is also based on your up-to-date screening history, your past medical history, et cetera, et cetera.
Gotcha. Well, thank you, thank you, thank you. We've got about 2 minutes left, Dr. Hogarth. I cannot thank you enough for taking the time out, especially on your family vacation in Wyoming. I hope you have beautiful weather and enjoy the rest of your time there.
Well,
And
I can't thank you enough for having me, but I can only apologize for my technical challenges. Like I said, when you and I set this up, I was supposed to be sitting there right there with you,
I know,
and
I
it
know.
was going to
Next
go. And I think
time.
we booked it for 2 or 3 hours, right? I know. Please,
It was
I
going to
very
be a
much want to be
2 hour
there.
meeting. Yeah, no, we will definitely, as soon as this world, returns to normalcy, you will be first on our list for sure. So
So,
thank you.
the sign behind you says it all. I mean, there in this field
Mhm.
right now, there is so many advancements going on at all stages, and even in someone who's got a nodule. It has been such a wonderful journey for people like myself, who, when I first entered this field out of training, uh, it was not very great news frequently, and to on a daily basis have better things to offer my patients. I mean, it just makes my job easier and easier, and I love sharing that with my patients. So, thank you for
Wow.
having me.
You're very, very welcome. Thank you for everything you do. I'm going to go through a little bit of housekeeping before we sign off for the night.
Okay.
Again, I want to thank all of you who were able to join our Voices Advocacy Summit over the last couple of days. Thank you for helping to make it such a huge success, and a huge shout out to all of my colleagues who worked so hard to make that happen. I will tell you, if you have not signed up yet for our virtual Summer Jam 5K Your Way, that is this Saturday, and it is not too late. So if you are interested in signing up, I think we still have a handful of states still to get on board with that. Please, please, please go to our website at gotofoundation.org and sign up. We'd love to have you. It's going to be a really fun virtual, I think, experience for a lot of people. Our next living room is July 21st. With Dr. George Nieva from University of Southern California, and we are going to be doing our annual Best of ASCO. So all of the latest data and information that came out of the ASCO meeting, the American Society for Clinical Oncology meeting that was a couple of weeks ago, we will be sharing in layman's terms, of course, with all of you. Again, I want to thank our supporters, Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Foundation Medicine, Genentech, Jazz Pharmaceuticals, Lilly, Merck, and Takeda. That's a really long list, and I think that long list points back to how important people think that this program is. So, huge thank you to them. Thank you to Peninsula Television, as always, for hosting the virtual backend now, hopefully soon to be the live in the room backend. Great job done by all. And then last, but very most definitely not least, thank you to all of you watching, to all of our patients, caregivers, industry partners, to just all of you. Thank you for watching us. And of course, again, Dr. Hogarth, thank you so much, and enjoy the rest of your week.
Thanks so much.
Everybody take care, and we will see you next time.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.